are you?
I'm great. It's good to see you.
It's great to see you. I was just letting people know that you are about to join us. And now I would like to start by introducing you to the Alloy community.
Sure.
Dr. Carolyn Moyers is a board certified OBGYN with a unique specialization in neuromusculoskeletal medicine, making her one of only 2 OB-GYNs in the country with this fellowship training. She is a Menopause Society certified provider and fellow of the International Society for the Study of Women's Sexual Health, that is ISWISH, and she is the founder of Sky Women's Health, a specialized gynecology and osteopathy practice in Fort Worth. Dr. Moyers provides concierge care focusing on addressing perimenopause transition, menopause, genitopelvic pain, sexual health, and minimally invasive surgery. She hosts a weekly women's health podcast, Sky Women's Health Podcast, designed to empower you as your own healthcare advocate to help you live your best life. Welcome so much. I'm so glad you're here. It's so great to speak with you. So, just to lay the groundwork for us, I did mention that we're speaking about the start of MHT, what to expect, how you should expect to feel, how to advocate for yourself if you're not doing so great. And if you would just sort of give us an overview of perimenopause. So someone's coming into your office and they start to say, I'm not feeling so hot.
Yeah,
What might you say?
one of the most common reports I hear is I just don't feel myself, right? Women just don't feel at home in their bodies anymore, whether it's mood or their agitation or their periods have gone off the rails. There's so many changes that impact us in perimenopause, and the symptoms of menopause and perimenopause look very similar. We're just still menstruating, right?
Right.
And perimenopause are those years around menopause. So they can last, those symptoms can last 7.4 years, 10 years in women of color. So it is not a small phase of life in which we're kind of feeling out of sorts.
And what are some of the symptoms people may come to you expressing?
What do they not
Okay,
experience?
let's work
So
backwards.
we always think of hot flashes and night sweats, right? But not everybody has hot flashes and night sweats, and not everybody immediately is presenting with those symptoms. Very commonly, it's now I'm the things that I used to do no longer work, and I can't lose weight. I'm putting on pounds. My midline is thicker. I'm very uncomfortable with this. I've got agitation, poor sleep. We start seeing more changes in mood and depression. Um, Inner ear issue,
Yes.
and skin itching and tingling. So there's just so many symptoms that can present. And oftentimes in perimenopause, that first symptom is a change in our menstrual cycle because
Okay.
of the fluctuating hormones.
And so let's say someone comes to you and she's in her early 40s and she's still getting a period, although it's changing. Maybe it's not really changing in frequency yet, but maybe it's changing in consistency, or it's as
A
one
change
woman told me
from
years,
their
a
baseline.
change from their baseline. One woman said to me years ago, I'm hemorrhaging
Yeah.
every like 10 days or something
Yeah.
like that. So changes can occur. When do you offer MHT? When should a woman consider starting MHT as opposed to the pill, which I know is really
Yeah.
popular?
Yeah. So in perimenopause, now you asked me kind of what is perimenopause and kind of time frame. One of the rhetorics that we hear so often is that you're too young, and that really gets me. And I know it frustrates a lot of people who go to their providers and they are told you're too young. This isn't, and it's almost like their symptoms are dismissed. But just because labs are normal doesn't mean that it's not perimenopause, right? And so, in regards to when you should start symptoms, first of all, we do labs in perimenopause to rule out those underlying causes, because a thyroid disorder or insulin resistance, diabetes can absolutely cause um, an irregularity in your cycles, right? So we want to look for, is there a root cause for what's going on? But hormone testing in perimenopause typically is not helpful. So just because your labs are normal does not mean that you're not perimenopausal, but what often happens is that women feel this pat on the back, go about your way, you're fine. The PCP says you're normal, it's okay. And she's left feeling like, but I don't feel okay.
Mm-hmm.
So when do you know what to start? It really depends on what are those underlying causes? What are the most bothersome symptoms? Did you tolerate birth control pill or, a combined hormonal contraception of some sort, whether that was the pill, the patch, the ring, um, it well in the past? If you've tolerated it well in the past, those are generally people who may be good candidates for that. And also, do they have permanent sterilization on board? Do they have sperm in their life? Do we need to worry about that contraception piece,
Right.
right? So that's a very detailed conversation to have. If they've had
Sorry.
permanent sterilization,
I'm thinking, do you have sperm in your life? I've never heard it put that way. Interesting. I like it. Okay.
some people
Something
have
to
not had permanent
consider.
sterilization and are sexually
Sure.
active, but do not have sperm in their life.
Yes.
So they don't
I,
need the protection.
I am so glad to have learned that term. Go ahead. I'm sorry.
So some individuals who are perimenopausal will do well and kind of transition through with a birth control pill and or some form of combined hormonal contraception. And then around the average age of menopause is when we would transition them to more traditional hormone therapy. However, some people never tolerated it well and don't like that thought at all and want to be on something that is more bioidentical versus synthetic. And that's when we can use more traditional hormone therapy. And I have seen it improve your cycles. So it does work to some degree. It's just not going to regulate your cycles quite as well as traditional combined hormonal contraception does. Now, one of my favorite options for perimenopause is a progesterone producing IUD, like the Mirena IUD or Liletta, which are 52 milligrams of levonorgestrel. We put it in locally at the uterus, and then you can use a transdermal estrogen of your choice.
Okay. I'm sorry. I was just coughing. I wasn't cutting you off.
Oh,
All
you're
right.
fine. You're fine.
Thank you. Thank you. Okay. So now for a woman who has begun, and let's say we're talking about the combination of estradiol and progesterone because that woman still has her uterus and needs to have progesterone. What are some things you might share with that person or any other who's taking it in any capacity about what to expect during the transition?
So, with any new hormonal method, whether it's a pill, a birth control pill, or some combined hormonal contraception or traditional hormone therapy, when we're giving exogenous hormones, there will be a transitional period. And so, typically, I'm telling individuals to keep their menstrual diary because it may take 3 to 6 months for us to kind of regulate, and also their symptom diary.
Hmm. And what might someone expect? I think, so often, excuse me, people are sort of, we have an expectation that we should be feeling better, period. But this could take some time. So are there anything, should we be looking for menstrual changes to somehow regulate or change again? Acne clearing up,
Yeah.
body odor changes, things like that.
Right, right. Well, I mean, of course, the most common symptom is feeling better.
Mhm. We hope so.
Yeah, that really truly is. But yes, it may be a period for us to get there. I typically tell my patients on average 3 to 6 months for us to get to where you're feeling more yourself. And then there's always an outlier, who it may take 18 months. But I think that the key is to know that yes, there may be some transitional time where it takes a minute for your cycles to kind of regulate. Maybe this option doesn't work for you and we need to make a transition. Maybe you have some bloating. Maybe you see the number change on the scale. Maybe you've got worsening headaches. Maybe your
Mhm.
headaches are improving. Maybe agitation worsens. Maybe it improves. Maybe you're overly tired. Maybe you have bloating. Like all of these things can potentially happen. Breast tenderness is another common one. But typically, these resolve spontaneously. And I don't see them as often in my perimenopausal patients as much as postmenopausal patients because you've
Well,
already got hormones on board, right? They're
okay.
just doing this.
Okay. Okay.
So we're
Okay.
helping to kind of regulate them. And so most of the time, yeah, there's a transition period where you just need to monitor those symptoms and keep your menstrual diary, and we can kind of go from there. I think the important thing to note is that if it's not working for you, if you're having an adverse reaction, if you just don't feel well, like I was talking to somebody this morning before our call, and she was having worsening gas pains on her progesterone. So when we are not tolerating progesterone, we have options. Do we want to administer that micronized progesterone vaginally? Do we want to just take it the 12 days out of the month for endometrial protection? You know, there are definitely options. And I think having a close relationship with your provider who understands the hormones and can make those adjustments is really key.
Yeah, thank you for that, Dr. Moyers. And I do have to say that's what I know you're doing in your practice, and we're certainly doing it here at Alloy. Speaking to somebody who knows the science and the literature specific to menopause hormonal care is crucial.
Yeah.
If you could just help us unpack a little bit more, what might be, and maybe there's nothing common, maybe you need to correct me on that, but what could be something that is typical adversely, even temporarily? So you mentioned headaches, you mentioned your,
Acne,
okay, that's another one that someone might
yeah,
expect, or,
bleeding,
okay,
bloating.
okay.
Yeah.
And again, you expect these things to just resolve themselves over time.
Oftentimes they do, or we need to make some dose adjustments. And so it's very specific
Okay.
conversation, you know, for each individual.
So tell us a little bit about that dose adjustment change, because I hear this and I repeat this quite a bit as well, that women should not be sort of turned off or fearful about hearing from their menopause specialist, let's tweak this or let's tweak that. So could you give us some examples of what you might tweak?
Yeah. So it depends. Like if they're still having hot flashes and night sweats, then their estrogen probably needs to go up.
Okay.
If they're having some breakthrough bleeding, I need to may need to raise their progesterone. You know, it really is dependent on what their specific symptoms are in terms of what we need to edit. If our hot flashes and night sweats are gone and our bleeding is just as we want to see, you know, they're pleased with those results, and then they're like, I'm still just fatigued. You just feel this lack of drive or oomph for life. You know, the next place I go is testosterone. Do
Okay.
we have physiologically low testosterone? Do we want to try to replace the testosterone? You know, there was a study that came out of the UK recently looking at testosterone use in peri and postmenopausal women and mood and cognition and saw a significant improvement.
Interesting. Okay. Someone mentioned hives. I don't know if she was getting them from the estrogen
I have had an
MH.
Yeah, I have had an individual who had allergic reaction to the patch. So, I mean, that's important to know is that when I think about our hormone replacement therapy, I would tend to say, you know, we have buckets, and I'll draw this out for patients sometimes on the paper on the table and say, you know, we have this bucket for systemic hormone therapy, thinking whole body hormone
Mm-hmm.
therapy. And we can put in that bucket our estrogen, if we have a uterus, our progesterone, and testosterone plus or minus, right? And in that bucket, you can have so many different options for how you administer it. So if your hormone therapy isn't working for you, it's either the dose, the route, or the formulation, right? And
Mm-hmm.
so knowing that you have options within that. So the estrogen can be given in a pill, it can be given in a patch, it can be given in a gel, it can be given in a spray, it can be given in a vaginal ring. You know, knowing that you have those options to kind of tier with. And you know, some patients have funny reactions to different things and just cannot tolerate it. So I have had a patient who had significant hives from the transdermal patch and we had to switch to the gel.
That's so helpful. Thank you for laying that out. So there's
Yeah,
various ways to get your estrogen, various ways to use your progesterone. There are
correct.
options for
There's
you, and don't be
options.
surprised if something isn't working. I had tried the patch for a time. I just found that I preferred oral. And it was one of the reasons was it seemed silly, but it was bothering me. I was also having an adverse reaction to, I guess, the adhesive or something of the patch.
Right.
And it was also sort of staining my skin. And I think for darker skinned women, that might be a bother as well.
Yes.
Um, and it's a minor thing. Use what's best for you, but another thing to keep in mind. Um, why is it so important for women to be proactive about their hormonal health? You know, and I'm thinking about sort of quality of life as you
Yeah.
age.
Yeah, that's exactly what I was thinking of. It's the quality of life. Honestly, we want to live well, we want to thrive well, as we start entering midlife, whether we're having symptoms of perimenopause in our 30s or in our 40s, because average age of menopause is 51. Most women are going through menopause between 45 and 55. Early menopause is that 40 to 45. Premature menopause is anything before 40. So I think it's important for people to kind of know a timeline and a lay of the land. And if you're in premature ovarian insufficiency or that early menopause, it may require higher doses, significantly higher doses for you to feel well. And so many of us are suffering and muddling through when we're at the height of our careers. We're raising kids, we're trying to balance all of the things, and we just can't keep all the plates turning anymore.
Right. Um, Dr. Moyers, could you help us sort of understand just to that sort of healthy aging perspective point?
Yeah.
Could you help us understand what estrogen is actually good for? So you've laid out kind of the
Yeah, yeah,
symptoms that it helps to
yeah,
temper, but
yeah.
what are we talking about when we're talking about healthy aging as far as
Yeah.
estrogen?
So cardiovascular health, it's cardioprotective. It is a vasodilator. When it's started early, which before the age of 60 or within 10 years of menopause, we believe we see a benefit in dementia and Alzheimer. We also see an improvement in bone health, bone density, preventing osteoporosis. So for our heart health, for our mental health, for our bone health, it's very beneficial. And there was a study that came out this summer looking at individuals 65 and older, those who had discontinued hormone therapy or never used hormone therapy versus those who continued their hormone therapy. And this was looking at a broad spectrum of different doses and formulations versus the WHI, the Women's Health Initiative, that only looked at one dose, one formulation, right? And so this individuals or this group of women, we saw an improvement or decrease in breast cancer, colorectal cancer, dementia, heart attacks, blood clots, to name a few.
Wow. Okay. That's amazing. Um, can you talk a bit about vaginal estrogen?
Yeah, so
How,
that's the other bucket.
yes, talk about the other bucket.
Okay, so the other bucket, we have our systemic whole body estrogen or hormone therapy, and then we have our local intimate skin therapy, which is so very important. And I would say probably at least half of my patients need both systemic and local
Let me
intimate
pause you
skin
just for
therapy.
a second. So I'm thinking again about the perimenopausal woman. So maybe she's in her late 30s and she's
Yeah,
not. When can she start? When are you having this conversation about vaginal
yeah.
estrogen with
When she
patients?
says she has vaginal dryness, when she
Okay.
says sex is uncomfortable, when she says I keep having urinary tract infections, when we're seeing recurrent BV, there's so many indications. So vaginal estrogen helps to preserve the vaginal epithelium. So the walls start to thin as we age. And I give everybody this illustration in the office.
Yeah.
I'm slightly embarrassed that I'm going to say this publicly, but
Not at all.
our
But
vagina on estrogen is like a Ruffles potato chip, right? Ruffles have ridges, they're nice and hearty. You can dip them in any party dip. Okay.
what? I am loving it. Okay.
Okay.
I love
As
it.
we
Yeah.
age and we start to lose that estrogen, what starts to happen is those vaginal walls start to thin. And it's more like a Lay's potato chip, right? You can see through it. It's thin. It has no holes.
Wow.
Okay.
Yes. Okay.
So the urethra becomes more prominent. We are less able to maintain that vaginal pH. We get more urinary tract infections, more vaginal infections, more irritation, just fissures from wiping,
Yeah.
This is very bothersome. Or individuals saying that, with penetration, it burns. None of this is fun. Talk about quality of life. So so I love vaginal estrogen in the postpartum period when people are nursing because it mimics menopausal symptoms, but also in this perimenopause and menopausal phase.
Dr. Moyers, I just want to I'm seeing a couple of questions about vaginal estrogen that I want to
Yeah.
ask you. One is, um, can you use vaginal estrogen as systemic therapy, or is it too weak? Would you clarify this?
Yes. No, it's not systemic therapy.
Explain to us
It is just for
again
local
what systemic
intervention.
therapy is.
Whole body therapy, thinking it's raising your blood levels, it's elevating your estrogen
And
levels.
you're getting that orally via patch,
There is a gel
spray.
specific or spray specific to whole body therapy, so it's higher doses. Now, is there a vaginal estrogen ring that is just for local intimate skin therapy? Yes. Is there a vaginal ring that also is a higher dose so that it is systemically absorbed? Yes. So I see how that could get confusing.
Okay. And another asks, would vaginal estrogen be appropriate for a woman in her 70s that has UTIs? Please
100%.
weigh in on this. Yeah. Can you
100%.
expand that a
Oh,
bit
yeah.
for us?
One of my favorite patient scenarios, 68-year-old individual who had seen the urologist, who had been admitted with urinary tract infections, who had just gone through the ringer, wasn't sleeping because she was up and down to void all night long, was to the point of feeling suicidal. And when she presented to my office, how she got to me, I'm not quite sure. But I said, my dear, you need vaginal estrogen. We treated her with vaginal estrogen. By her 6 to 8 week follow up, she was singing my praises, thought I was a miracle worker. And it was just the vaginal estrogen.
Yeah.
But it cured it. It cured her symptoms. She was sleeping again.
That's amazing. I will often say that vaginal estrogen is the prevention, the treatment, and the cure for so
100%.
much. And it can effectively stave off, for some women, death in
Yes.
their older years who
Yes.
become. Can you
And I
talk
think
about
that
that?
it is confusing to individuals because they're like, well, I'm on systemic hormone therapy, but if you're still having symptoms, then we just need to put it where we need it, right? We
Right.
need that vaginal estrogen. The vaginal estrogen does not increase your blood levels, so it's not systemically absorbed. So it's not a high enough dose for that. And so taking both, it's not like we're going to raise your levels significantly. It's not increasing your risk. It's doing nothing but um, really protecting that intimate skin. And I always say, we have 15 regimens that we'll do for our face.
Right. Right.
Now we just have to take a little bit better of the skin in our intimate region.
Yeah. Dr. Moyers, you said a few minutes ago, when she tells me, when she tells me, when she tells me. So you have created an environment in your practice where a woman can come in and feel open and able to share with you what may be going on with her, how she's feeling, how she's hurting in various ways. We certainly do that on our platform, kind of make that space and shout out loud, let us know how you are. But there are so many women who are well into perimenopause, who are in menopause, who aren't sure if they are perimenopausal yet. They're not feeling it themselves, but they are not about to say it out loud to anybody, because I think women, by and large anyway, will deal. We just sort of deal. We go on, we put it down, we set
We push
aside, we don't
through.
think about it. We
Mhm.
push through, and or we're not saying these things out loud yet. So I just want you to speak a bit about how to self-advocate and how to become aware. You mentioned keeping a log, a menstrual log, a symptom log. I think that's a fantastic way to kind of tune in. But talk to us about how to talk about this.
I think you just start by having the conversations, with whether if you're not comfortable having it with your friends because you think, well, maybe I'm too young, they wouldn't understand, or even your partner, maybe you feel like they're dismissed. Schedule a consult with a menopause expert to give you some good advice, some unbiased opinion. I think that really deep diving and giving women the space to be seen and heard is so incredibly important. And I think that because women are demanding for more for appropriate care,
Right.
the care that they've so well deserved for so long. This is why, like, the Menopause Society meeting was sold out this year. We have more people who've certified in the last 6 months than the previous years. I mean, it's very exciting that because women are listening as the menopause is coming more vocal, they're listening, they're demanding it, and providers are understanding I need to beef up my knowledge here.
Yeah. And I think I will feel like success is complete when providers across specialties are aware of this season of
Oh,
life for women, right?
yes,
It's not just the OBGYNs, but
yes,
all of it. Eye doctors,
yes,
dentists.
yeah. So
Right.
I am so tickled whenever somebody says my PCP sent me to you because he noticed that my lipids were elevated and they said, hey, this could be perimenopause.
Wow. Is that happening?
I'm like, yes. I'm like, tell me who that is.
Yeah.
I'm writing them down. They're going to be on my preferred list now.
That's amazing.
That is amazing and very insightful. I often find also that if it's a male provider, it's usually like their wife has gone through it and now they're like, okay,
Sure, sure. People become sensitive to something happening in their own home.
yeah.
Um, Dr. Moyers, you mentioned you went to the or did you go to the Menopause Society
I attended
conference piece?
virtually this year.
Oh, you
Yeah,
did
I
it
had
virtually.
another commitment. Yeah.
Were there any takeaways that you would want to share with us now?
I mean, so many. How could I condense that?
Is there one that
um,
stood out?
so I really loved that they talked a lot about mental health. They talked a lot about obesity and diet and, all of those things. So I was really impressed with a lot of the lectures. I loved hearing what's going on with the initiative with the government and our women's health research dollars and collaboration. I think that that's exciting. So I keep telling women to keep being loud, keep advocating because it's so important and it's moving the needle. I did a podcast episode on, some highlights from
Oh,
that.
great. Oh, good.
And
All
also,
right.
I have a podcast episode on what to expect when starting hormone therapy. If anybody's interested, it's Sky Women's Health.
Terrific. And thank you for letting us know that. I appreciate that you brought up the mental health piece because I think that that part is often the first and the loudest symptom over
Yeah.
time for women in perimenopause, and it's often overlooked. Can you talk about that and what to do if a woman says, I don't want to take an antidepressant, or,
Yeah.
how to address that?
Yeah, I mean, I was so fed up with everything being, oh, she's hormonal,
Hmm.
or like I feel like that's so dismissive because aren't we all?
Hmm.
you know,
Yes. Yes.
I think it's really dismissive. But yeah, mental health is a huge piece that I think we in this country have often just ignored or made taboo. And so I think it's very important for us not to ignore that. And it usually does take a combination. Like, so do we see that in perimenopause sometimes hormone therapy actually is as effective as going on an antidepressant? Yes. So
Mhm.
it can improve mood. This is very true. Now, could there also be significant other things going on? And oftentimes, you may be dealing with spouse's illness or parents' illness or stresses with kids and or teenagers or whatever is going on in your life. There can be tremendous stress that is impacting sleep and therefore mood and agitation and all of the things that go with it, right? But then if you add in some true clinical depression or bipolar or any of those things, all of a sudden you may be kind of pushed over the edge. So hormone therapy can be beneficial to help regulate mood. I have had people be able to come off of medications after getting on their hormone therapy, but I do think that it has to be collaborative. We've got a counselor, we've got a psychiatrist, we've got your hormone specialist kind of on this team to help you through that.
Yeah, thank you for that. I think, what I will often say and certainly hear from specialists is that hormones can be a first line of defense and sort of get you back to neutral
Yeah,
before you start exploring other things. And this is a case by case situation. I'm by no means suggesting people not listen to other clinicians,
yeah,
but also the potential for the relationship between a menopause specialist and any other practitioner to come together on behalf of a particular woman is critical. Someone asked about PMDD. Could you tell us what that is? And And I'm also thinking about women who may have a difficult PMS, sort of in their teens, 20s. What might they expect also when they enter into perimenopause, and how can MHT be helpful?
Yeah, so premenstrual dysphoric disorder, it's a chronic mood disorder, causes severe mood swings, irritability, depression, anxiety. Um, in the week prior to or and the week of the menstrual cycle, typically. Usually once that menstrual cycle starts, we see an improvement, and it's because of the hormonal changes. And we often do see improvement with regulating cycles, with regulating hormones. And we know that in the PMS, in those earlier years, that a combined hormonal contraception and or an antidepressant can be used for treatment. And that may continue in perimenopause, right? But it also maybe, like, every individual is so unique. So I hate to give a blanket
Sure,
statement,
of
but
course.
it may be that they can transition to some more traditional hormone therapy and have that same benefit. But it
Okay.
usually is some combination. It may not just be one or the other. They may
A
still need
combination
of
of,
an antidepressant, an SSRI, and hormone therapy.
okay, so you talked about the birth control pill, MHT, tracking your symptoms, the impact of life stressors, vaginal estrogen, the ways to take estrogen and or progesterone, that you really, your mid to late 30s is certainly a time to start thinking about this. Tracking your symptoms can really help you do that well. For any woman out there who's thinking, I may be perimenopausal, and she's still unsure if MHT is right for her, um, how can you help her make an informed decision?
So there's so many great resources, like the book Estrogen Matters, like the new Menopause book by Dr. Mary Claire Haver. There's so many great resources and so many on social media talking about it now, many of your doctors. But I think having a detailed conversation about your specific health and symptoms is so very important. So finding a provider that you can relate to, that will listen to you, and that will run the appropriate tests to make sure, again, we're looking for those any underlying causes or any other health concerns that could be contributing to your symptoms. And then I often say, I don't have a manual for you. I'm not going to know what's perfect for Rachel, right? We've got to be willing to have this informed consent, this conversation, and this shared decision making, and just be willing to start. Just be willing to start somewhere and trial it and see how it goes. And if it doesn't work, have that conversation with your provider and transition to the next thing.
I love that. I think that arguably is the most important thing, being open to starting, being open to addressing your symptoms, and being sort of aware that you won't necessarily know what's right for me immediately. But if I'm
Mhm.
open to getting started, I'm open to feeling better. And that may take a little time and a little tweaking, and tweaking over time, right? So maybe you start somebody on something, or she's transitioning from the birth control pill to MHT. There is going to be a period of transition where things may feel, I don't know, a variety of different things,
Yeah.
but you are going to be able to help that person get to a better place. It's just going to sometimes take a little time.
Yes. Yes. And it's really just listening to how are you reacting? How are you feeling? I usually say, this is where I like to go back to, this is where we started, right? These are
Mhm.
the symptoms. This is the list you gave me when you walked in the door, right? Let's count our wins. Where are we now? And so many times I had this conversation this week. Well, I'm sleeping better. I'm not having hot flashes and night sweats anymore. I can wear pants for the first time in years, right? But I'm still just kind of fatigued, even though I'm getting my sleep. So
That's
then we
such
have,
a helpful illustration. I love that you shared that. I didn't mean to cut you off. Sorry.
no, you're fine. You're fine.
I think that's so incredibly helpful and a good way for women to kind of advocate for themselves. And
Yeah.
again, another great reason to track your symptoms. Go over your wins and your what you still could use some support with, bring that to your physician, have that conversation, and see where you land.
Yes, yes. But and I think that if you have see a menopause specialist and they say, see you next year, or if you see your OBGYN, they give you a prescription and they say, see you next year, that's not the right provider for you. Like typically you're going to throw them out the window because it's not going to work. You didn't like a side effect, but you don't feel like you have that relationship to say, hey, I need to raise my hand here. This isn't working for me. It really takes a close relationship.
Awesome. Dr. Moyers, is there any final thought you'd want to leave all of us potential patients with?
Mhm. Well, we didn't even address the big elephant in the room about the concern for
Say it.
cancer. You
Okay,
know, I mean,
let's do
come
it.
on. We
Let's
have
do
to
it.
we have to say that the Women's Health Initiative, the average age of the individual was like 63, not who were typically starting on hormone therapy. It was blown up by media. It was very much scare tactics. They have walked back all of those claims now. Hormone therapy does not cause breast cancer. May you get breast cancer? Yes, but guess what? Individuals who are on hormone therapy who get breast cancer during that time frame actually fare better. And so I don't want individuals fearing it. Now, are there people who can take hormone therapy? Of course. I have a patient who's had multiple pulmonary embolism, multiple blood clots. She's probably not the best candidate, but we have other options. There are non-hormonal options as well. So don't fear it because we know that it protects our bone health, our cardiovascular health, our cognitive health, and our quality of life. So just have that detailed conversation with your provider so that you can make an informed decision for you. Be empowered.
Thank you so much for raising that issue and clarifying again what the impact of the WHI was to a generation of women.
20 years of women and physicians who have been undereducated, undertreated.
For a patient, I'm just imagining someone coming to you and saying, I'm just not feeling well and I'm not sleeping and I'm hot flashing and whatever other lesser known symptoms she might be sharing. But my mother had breast cancer, so I'm nervous about it. What's your response?
Most of them are not inherited. So, I would say, would it make you feel better to do some genetic testing? A more detailed conversation about her specific health would be really important. And even some breast cancer survivors are on hormone
Yeah,
therapy
yeah.
again, because it's very specific to you, and quality of life is so incredibly important. And I think that just is such a it's almost part of our DNA now that we just absolutely believe that this causes breast cancer, and undoing it is like trying to put the genie back in the bottle. It's
Mhm.
so challenging.
Yeah, I can see on your face you're sort of like, that's ridiculous. Just get on the hormones. But you're being very careful, and I appreciate that. But I also I see it, and I think for doctors who are well versed in the science and the literature now, they're able to have conversations, really allay people's fears. But at the end of the day, most of you are kind of like, you're gonna be okay. You're fine. The risk is not there like we thought it was.
And I think we have to take it into perspective, right? Because our hormone levels, our estrogen, progesterone levels are the highest when we're pregnant. We have a risk of having a blood clot when we're pregnant, or you know,
Mhm.
much less so when we're on birth control, but there's a risk when we're on birth control. That risk is much lower when we're on hormone therapy. So it's all relative because it's
That's
lower
so helpful.
dose. Mhm.
Yes. So MHT is a lower dose of hormones than birth control, is a lower dose of
And
hormones
pregnancy.
than pregnancy. Listen and hear that, ladies. I love that. If you take nothing else, anything else I missed?
I think we covered it.
Okay. Okay.
Oh, you know what?
Dr. Yes.
I did see a question about vaginal estrogen. They were
Oh,
asking about
oh, great. I
dosing
missed
and
it. So
so
please, yeah.
vaginal estrogen, didn't say that it can be given in a cream, in a tablet, in a suppository, in a ring. That's all vaginal estrogen. Or you can do a vaginal DHEA, which is a precursor to estrogen and testosterone. And that works really well, especially in postmenopausal women who have dyspareunia, painful penetration.
And that DHEA is a cream.
It is a suppository. It's a nightly suppository. So most vaginal estrogen is like 2 nights a week or 3 nights a week, depending on if it's the cream or the tablet or the suppository. The ring is put in for 90 days. The vaginal DHEA is one that is a nightly suppository. And so for some people who have a difficult time with compliance, some of us aren't great at remembering and changing things
Right.
twice a week.
Yeah. Yeah.
Then I generally will offer then the vaginal DHEA because it's just that repetition, right? We get into the habit.
Okay, terrific. Thank you so
Yeah.
much for that. Um, Dr. Moyers, this was chock full of lots and lots and lots of critically helpful information. Thank you so much for explaining and exploring and unpacking what's available to us, what we can expect, how we should be feeling. And I think in many ways, the biggest takeaway is speak up, let people know how you're doing, let your trusted practitioner know how you're doing, find a menopause specialist if it's Dr. Moyers personally, or if it's any one of our trained physicians at Alloy. Um, you need not suffer in any way, and it's nuanced care. So you definitely want to speak with somebody who understands
It's
the science.
very customized. Yes,
Thank
very customized.
you.
Yeah.
Thank you so much. Thank you guys who joined today. I appreciate it. I wish you, Dr. Moyers, a happy weekend and
You
everyone
too.
else as
Always a pleasure
well.
to see you.
Always, always. Thank you, thank you, thank you. Bye, everybody.
Bye.
Thanks, Dr. Moyers.